Hi, I'm Terry Dickerman. So I started out as an LPN back in 1972 caring for critically ill children on a 36-bed ward in Syracuse, New York. And while working as an LPN and raising my family, I earned my registered nurse with an associate degree in 1981. Critical care nursing has been my primary background, with mental health added in the last 25 years. I have 6 children and 26 grandchildren, which are my pride and joy. At 74 years of age, I am earning a degree in the mental health nurse practitioner program at Southern Adventist University. My goal is to be a light in the tunnel of darkness to the depressed and downtrodden as I finish up my work for the Lord on this earth. My worship thought is about people who have suffered, reconstituted in their lives, and they describe themselves as becoming much richer for the experience of suffering. They have an urge to give back, to help those who are suffering get through the experience. In my text, I have 2 of them. The first one is Romans 5:3-4. Not only so, but we also glory in our sufferings, because we know that suffering produces perseverance, perseverance, character, and character, hope. And the other one is Mark 10:24. Suffer little children to come unto me, and forbid them not, for such is the kingdom of God. And I know that through all of the heartache that our family has been through this year, that God allows these things to happen so that it will build our character. The historical information of Morse and her theory of suffering, she is a professor and presidential endowed chair at the University of Utah College of Nursing. And she has her PhD in nursing and also in anthropology. Her research programs are in the areas of suffering and comforting, preventing patient falls. She's the author of the Morse Fall Scale, which is used internationally to triage the fall-prone patient. The suffering and enduring research focuses on redirecting theoretical basis of nursing to patient experience and exploring non-pharmaceutical means to ease suffering. So many times we are just taught to analyze for pain, but we've never really been taught to analyze for suffering in a patient. Her honorary doctorates were awarded her from the University of Newcastle in Australia and Athabasca University in Canada. She's the author of 460 articles and book chapters and 21 books on qualitative research methods, suffering, comforting, and patient falls. With her model of suffering, the model summarizes the behavioral experiential nature of suffering. Suffering is perceived as comprising 2 major behavioral states: enduring, in which emotions are suppressed. It is manifested as an emotionless state. And emotional suffering, an overt state of distress in which emotions are released. Individuals who are suffering move back and forth between these 2 states according to their needs. Their recognition, acknowledgement, acceptance of events, the context, and the needs and responses of others are implications for the provision of comfort during suffering states. That's what is presented here. The worldview. Caretakers of suffering are nurses. Nurses have to stand firm. They understand the suffering patient, their responses, and their needs. Nurses feel this settling very heavy on their shoulders. The heart of nursing is the ability to ease and alleviate suffering, and as we know, there's suffering all over the world. The nurse sometimes is the only support to support the family of the patient along with the patient. The four metadimes. In nursing, we observe suffering. We link emotional responses with behaviors. In the patient, we observe the plight of the sufferer. The response from others to the patient greatly affects their health. The nurse guides the patient through their course of suffering by evaluating and controlling the environment to keep their environment as safe as possible for them. Sometimes you may have to ask family to back off or leave the room, or just keep it calm for the patient when they're going through stress. Evaluation of the theory and model. Discovering the behavioral experiential environment of suffering. Suffering encompasses two foremost behavioral conditions: enduring and emotional suffering. Enduring embraces emotions that are they're suppressed. Enduring to survive, to live, and to die. We endure in all those three situations. Emotional suffering is an obvious state of distress in which emotions are unconstrained. And if they're too unconstrained, you may have to medicate the patient before you can approach them. Sufferers move back and forth between these two conditions according to their own requirements. Their acknowledgement, recognition, approval of events, the circumstances, and the wishes and reactions of what others have. Careful attention is given to the patient's actions to identify which state of suffering they are experiencing, and you as a nurse may be the only one that can evaluate that. And you also have to be able to assess what phase your patient is in, so you can intervene with nursing interventions to assist him. Examples of how the theorist is used: education. Teach nurses to observe and identify behavioral states of patients. 6 of the behavioral states are unconscious, relaxed, scared, afraid, terrified, and out of control. The last 2 may be identified as a failure to enter the enduring stage. Nurses need to be taught how to comfort patients in all stages. Practice. Comforting strategies can be used on all stages of behavior except those who have lost control. These need to be medicated before trying the comfort techniques. Comforting strategies are eye contact and touch to move the patient towards enduring. Research. Research shows that those who are enduring do not move to emotional suffering until they are ready to accept their losses. This is really hard for some people. I know when we lost our great-granddaughter, there are still people in the family that can't accept it at all. Some get close to emotional suffering and are frightened, so the flipping back and forth begins between enduring and emotional suffering. Administration. The nurse evaluates the energy levels, the context of the patient's actions, and what available support the patient has to help stabilize his actions and assist in his progress. An application of theory to APN. The APN is the expert at evaluating the nonverbal behavioral cues of her patient. She can use her intuition, experience, or her human judgment in reading her patient's actions. Sometimes you have to spend time with your patient to even understand what they possibly might be going through. It takes time to listen to their stories. Sometimes if they're really needing to be medicated, the family can clue you in on some of the details. Being able to recognize the behavior pattern the patient exhibits as he suffers will allow the APN to use them to guide her in using therapeutic interventions. She will be able to distinguish which pattern they are in, enduring or emotionally releasing. And I know that we have all seen this. Those who are enduring do not need to be touched, only supported by encouraging them with words. Empathy should not be used. Emotionally, they are not present. And I have found this to be true. Anytime that I have gone out with patients, like when I worked in the units at Erlanger, because I guess I'm older, the younger nurses would ask if I would go out to the waiting room with the families of somebody that just died. Will you please go out, Terry? And I would always volunteer, because what they didn't realize is you don't have to say anything. All you have to do is just be there. You don't have to say anything. The emotionally suffering will react with a firm touch. You can hold and stroke. Voices of their caregivers console them, and they must be realistic. Closeness at this time is important. Conclusion. The APN recognizes the significance of knowing what stage of suffering her patient is in. In the past, the focus was on pain and other unpleasant symptoms, but nobody ever really taught us in school to look at suffering. And we know that these patients are suffering. When you take a baby to parents and the baby is deformed, not only is the baby suffering, but the parents are suffering. And so many times you avoid any connection, or you just don't know what to say sometimes. But you don't have to say anything to have that bond and to evaluate how they're suffering and how deep their suffering is. Using non-pharmaceutical ways to alleviate patients' suffering enhances the patient's ability to endure. And so many people, the minute they lose a mother or a father or a friend, they run to the doctor and they want Xanax or Valium or something to help them get through, but they're not touching with reality. So we need to really focus on the spiritual needs, try to evaluate how they're suffering, and just be there, even if you just stand there. The importance of recognizing the different stages of suffering allows the APN to assist her patient in the most effective way possible. It is becoming a legitimate coping style in attending to suffering as the basis of patients' needs, caring and offering comfort to their patient. And even if a patient has just found out they have cancer, people suffer when they hear that. I know when my husband found out that he had cancer, the doctor walked in the room and he says, "Well, I have bad news. You have cancer." And I thought that was really abrupt. I think that he could have explained that in a much better way. It's almost too shocking to be that abrupt. People have feelings, and we need to always have patients' feelings. Try to read them. If a person's real quiet, that doesn't mean that they don't have feelings. So I think the thing that really helps me is when I have patients, I am not afraid to pray with them. They can always say no, and sometimes I will just say, I'll be praying for you this week. And all my patients say they're really glad that I do. So working in hospice, I know that they're suffering, and you just have to be there for them. And it's encouraging for them to know that you are praying for them. Thank you.